Our featured speaker today is Jim Bolognese, Cytel Senior Director, Strategic Consulting. Jim, please go ahead.
Thanks, Rick. Good morning, everybody. Thanks for joining. This talk is about speeding early development using computer simulation and biomarkers. It involves a sequence of 3 trials, a proof of concept trial with a biomarker, followed by a dose-finding trial with a biomarker, and then a 3rd trial, a phase 2B trial with a clinical endpoint. And the purpose is to choose the correct dose for phase 3. This is joint work with 2 of my Cytel colleagues, Jaydeep and Nitin, listed here, and a multidisciplinary staff for the client with whom we worked on this project, a group at Merck. This is just a background on me. I'm at Cytel. I've been here 4 years. Before that, I was a statistician at Merck, and I've worked before on adaptive designs and all phases of drug development. And for those of you who know me, I'm certainly not dressed like that in the picture at this time. The outline of the talk today is to start with motivation for this work and then some background and an overview. I'll talk then about the particular development scenario that this work applied to, then move to an overview of the modeling, talk about the cases that were simulated, show you some selected results, and then sum up with conclusions. The sponsor was preparing an early development plan and had these questions in mind. How could they use the relationship between early biomarkers and the clinical endpoints to optimize their early phase development program? In particular, looking at improving the quality of the information and or the speed of the development program. Associated with this is how could different designs, consideration of different designs in phase 1, namely the proof of concept design and the dose-finding biomarker design, how could those different designs improve the design of the phase 2B trial? And how could they use the phase 1 data to optimize dose selection for that phase 2 trial? Would the use of that information allow reducing the phase 2 sample size or improve the chance of picking the right dose in phase 3 or for phase 3? So here's a schematic of their initial thoughts on the development program. They started with a biomarker POC trial on the left, and that was high dose versus placebo. And then there were some go, no-go criteria based on a Bayesian analysis of the data to compute posterior probability of response for 2 biomarkers that they were considering using. And then if there's a go decision, they'd go to the biomarker dose-finding trial, and they would add some doses and get biomarker information. And then there was the same go, no-go criteria. So if there's a go, then they move to the phase 2B trial with the clinical endpoint and leverage that information from a combined analysis of the first 2 trials to help design that phase 2 trial with the clinical endpoint. And then there's the same go, no-go criteria to phase 3 and a phase 3 dose choice. So the key objective is to design that phase 2B trial to maximize the probability of getting the phase 3 dose right. What we did to address the questions that were posed at the beginning of the talk was to use the pre-validated biomarkers and the prior data available to build relationship models of the biomarker to the clinical endpoint and model their time course. We then made our best guess as to the true values underlying that would yield clinically important response, and then simulated design options for the sequence of trials applying the go, no-go criteria. Then we summarized the results and produced a recommended development program that was actually better than what was originally planned. And we'll describe how that worked out later. What we learned from this exercise was that simulating a sequence of trials is useful in designing an early development program. We learned that in this case, biomarkers were useful for demonstration of proof of concept, but of only limited use for dose finding. And that finding allowed us to eliminate an entire biomarker dose finding trial from the critical path of development. And the resulting plan achieved an earlier start to the phase 2B trial. So now I'll move to just an overview of what clinical trial simulation involves, and then program simulation, and then the remainder of the topics. In clinical trial simulation, we define some true underlying scenarios for endpoints and different study designs and different decision rules. And then we generate many repetitions of the data through computer simulation. And then we summarize the results, compare them across the scenarios and the possible choices, and choose and justify a trial design by those simulations. And those simulations demonstrate the performance characteristics of the designs across a span of potential true scenarios. And this is widely used in drug development to design individual trials. What's newer is drug program simulation. In drug program simulation, one designs a sequence of clinical trial simulations and decision rules for moving from one trial to the next. And the aim is to optimize that sequence of trials for a particular set of drug program objectives. There is a body of prior work on simulating sequences of clinical trials, and they were targeted to the sequence of trials from phase 2 dose finding to phase 3, and then evaluating the impact of those designs and different design choices on the probability of program success, namely 2 trials yielding significant difference from control, and the impact on product net present value. The references of those works are listed here. And part of that was a DIA adaptive program working group in which I participated as a co-author on one of those papers. What's new is applying this, what we think is new is applying this program simulation to the early development space, and in particular optimizing the use of biomarkers. So what that involved in this case is to consider short-term, small sample size biomarker trials to optimize the phase 2 design, which is based on the clinical endpoint. And the aim is to optimize that design with regard to selection of the doses to include in that phase 2B trial and optimize its sample size. The aim is to improve the probability of selecting the correct dose for phase 3, and in particular to answer the sponsor's questions, which we posed at the beginning of this presentation. So here's a little bit lower drill down on what we did. As mentioned, we want to optimize the biomarker phase 1 to phase 2B space and program to improve the probability of selecting the correct phase 3 dose. So that program started with a POC, high dose versus placebo biomarker trial. And then if certain criteria were met, moved to a biomarker dose-finding trial, which added information of a low and a mid dose, again with placebo control. And then after completion of those two biomarker trials, we perform a pooled analysis of the combined information to get a dose-response profile of the biomarker, leverage the relationship of those biomarkers to the clinical endpoint, which we haven't measured yet at the appropriate time point, but predict what the biomarker tells us about that endpoint, and then use that information to pick the doses to include in a phase 2B trial. And then we use those doses in a phase 2B trial, simulate the results from the assumed true underlying dose-response relationship of the clinical endpoint to response, and then look at those data and pick a dose for phase 3 and compare that to what the true dose should have been. And that lets us know how good this program is doing. So this is the same schematic as shown before, but there's an additional item. Namely, if the results of the biomarker POC trial are highly robust, namely a much larger posterior probability for biomarker response, then we have an option to skip the biomarker dose-finding trial and move directly to the phase 2B trial. Now, we don't have dose-response information, so we have some pre-selected doses. So the aim here is to compare this rapid to 2B approach with the availability of the biomarker dose-response information and leveraging that to see how useful that dose-response information of the biomarker is in helping design that phase 2B trial. And again, the key questions are we making the right decisions to stop or go along the path? And if we go, did we get the phase 3 dose right? And how much of the time does that occur? So we compare this option for rapid to 2B with the original proposed sequence of trials. Here's the particular set of biomarker to clinical endpoint response relationship that we used and the true underlying dose-response curves that we used. Each of the biomarkers had the same Emax model with the values of the Emax model parameters listed here. For those of you familiar with an Emax model, there are 4 parameters. We always assume the slope is 1. The Emax response was standardized to 1, and the ED50 was 20 milligrams. The same ED50 was assumed for the clinical response endpoint, but with a lower Emax value. The variance-covariance matrix for the ED50s is shown at the top there in the upper right. And so we assumed a 0.8 correlation of the response for the biomarkers, but only a modest correlation with the clinical endpoint. And that was based on prior information. Then, because we are measuring the clinical endpoint at 2 different times and the biomarker information at 2 different times, we have an exponential time course factor that's included in the model. And we have a finite set of doses. There's a typo on this slide. The 25 should be a 20 because it's oh, no, that's not right. It was 25. The ED50 was 20. So we have this finite set of doses. And the target level of response is about 80% of the maximum, and that's an 0.4 level for the clinical endpoint. And the dose that yields that, so the true target dose is the 100 milligram dose. And the phase 1B, the phase 1 program, the high dose was 1,000, and the mid and low doses were 500 and 250. So the phase 1 trial used a sample size of 20 individuals versus 10 for placebo, and then applied the go, no-go rules based on the Bayesian posterior distribution of the responses from that trial. And then, if go, proceeded to the second biomarker trial, which added 20 response observations at the mid and low dose, and then 10 more on placebo, applied the go, no-go rules. And then there was a combined analysis to estimate the posterior distribution of the Emax model parameters if we followed the path that went through the second trial. And then that data was used to choose doses for the third trial, which was a 2B clinical endpoint trial. And there were a complicated set of dose choice algorithm. There was a complicated algorithm for dose choices, which yielded either 3 or 4 doses. And we studied 3 sample sizes for the clinical endpoint trial in 2B. And then after that result, we chose the phase 3 dose based on the posterior distribution of the clinical endpoint model fit at the end of the phase 2B trial. We assumed a linear relationship between the biomarker and the biomarkers and the clinical endpoint response, which was a 12-week response. When we had two durations of the phase 1 trials that we considered, a rapid response in which we couldn't measure the clinical endpoint, which is denoted as biomarker 3, and we had a 4-week option for that trial, in which we could get an early outcome for the clinical endpoint, namely the biomarker 3. So the aim was to compare whether it was worth doing a longer-term phase 1B trial to get an early read on the clinical endpoint and see if that would be useful in the dose selection process for phase 2B. We used the information then from this linear model, which was derived based on information from previous studies, and used that to predict the 12-week response. And then that predicted response was used to pick the doses for phase 2B. So this complicated schematic summarizes the software that was built. We had the Bayesian model machinery, but we didn't have the software to apply it to a sequence of trials. So just following through this, we start with the POC user inputs. We use those to execute the simulation engine and yield the POC trial output, apply go, no go criteria. If it is go decision, then we pull in the phase 1B design inputs and simulate the phase 2 information. The 1B dose finding information. unless there's a rapid to 2B result, and then we go directly to 2B. But if not, we get that dose finding. We go to the dose finding trial, run that simulation engine, and yield the dose finding results added to the POC results. And then we apply the go-no-go criteria to go to phase 2B or not. And if we go to phase 2B, then there's a similar structure for the phase 2B clinical endpoint. We get that output and we select the phase 3 doses and compare it to the truth, and that's the that's the key information we're looking for. So these are the factors that we sought to compare. We had that 2-day duration for the POC trial and the biomarker dose finding trial. And then we had the 4-week duration in which we could add the early read on the clinical endpoint. And then we had the 3 sample sizes for the phase 2B trial and the low, mid, high dose. Or maybe we added another low dose under certain criteria. Then other elements of the simulation were that we had 2 different prior distributions that were considered. There's an uninformative prior if we have the 2-day duration option for the early phase trials, and we have an informative prior if we get the early biomarker result from the 4-week phase 1B trials. We have this forced sequence of trial options that goes from POC to phase 1B dose finding with biomarkers and then to phase 2B, and we had this option for the rapid to phase 2B option, skipping the phase 1B dose finding biomarker trial. So that rapid to 2B option is confounded with the uninformative prior, and the forced sequence option is where we evaluated the informative prior because we needed that phase 1B dose finding information to evaluate that. And then the key metric that I'm going to show you, there were some other metrics that were actually summarized, but the key metric is the rate of choosing the correct phase 3 dose. And that's just computed from the proportion of simulations in which we got the phase 3 dose right. This slide summarizes the findings. We found that 2 days is sufficient for making the go-no-go decision. There was no added benefit of the second biomarker dose-finding trial. The next question is, could we use the phase 1B results for dose selection? And the results yielded a conclusion that the relationships between the biomarkers were too variable to drive the dose-finding decision-making. And the informative priors didn't help much at improving the probability of getting the phase 3 dose right. So that the optimal design was a fixed design for 2B with 100 sample size, maybe more, because when we looked at that fixed sample size, it yielded limited ability to discriminate between active doses and didn't have high probability of getting the phase 3 dose right. So we offer the consideration that a larger phase 2B trial is needed to have high probability of getting the phase 3 dose right. And I'll show you some of those results in the next few slides. This slide summarizes the 2-day versus 4-week option. In the case where we apply the uninformative prior for the 2-day option and the informative prior for the 4-week option. And we summarize the percent of simulations that are, the top row is at the target dose and the second row is near. This near is a typo, this is at. And then the percent where we got an estimated dose, but it wasn't near. Near means adjacent to. And then there's a percent of simulations where we couldn't get any estimated target dose. That is, the Emacs model fit was lower than the target of 0.4. So as you can see, the percents are within the simulation error. We simulated 500 simulations, and we chose 500 because simulating a sequence of trials and doing the Bayesian analysis after each one runs a very long time. So we ran 500 simulations, and the result was that there was no advantage of the informative prior or the 4-week duration over the two-day option. In the next slide, we look at whether the informative prior and 4-week option with a smaller sample size in phase 2B could match the short-term phase 1B option with the potential to rapidly go to 2B with that option and a larger phase 2B. And you can see just modest improvement in the percent of simulations at the target dose and a decrease in the percent of simulations that yielded no target dose. So this larger sample size, the informative prior and smaller phase 2B sample size was not an option that was as good as the rapid to 2B with large sample size option. Now, the results from the previous slide are copied into the first and fourth columns, and what we add here is what if we do a full-size 100-patient phase 2B trial and use the sequence of trials and the informative prior? Is that informative prior with the same sample size at phase 2 buying us anything? And in this case, the answer is not much. You get a generally similar performance characteristics with the 2-day phase 1 and phase 1 trials as you do with the 4-week trial where you measure the clinical endpoint and use an informative prior. So this is the key information that supports the rapid to 2B option, because there's not much gain in getting that phase 1B dose-finding information. But you also notice that the total number of simulations that yield a predicted phase 3 dose at or near the target is only around 50% or more. And so that leaves a question of how big does phase 2B need to be to increase that probability of getting the phase 3 dose right. And that's what's shown on the following slide. To run with increased sample size, we ran those with lowering the variance and yielding an effective sample size increase because we wanted to cut down on the runtime. But with the lower variances to yield increased effective phase 2B sample size, we find that you get high probability of getting the dose right with about 150, a little less than 150 patients per dose in the phase 2B. And that's more than you need to discriminate drug from placebo in phase 2B. At the bottom of the slide are sample sizes for 80% power and detectable differences from control. And the sample size of 100, which was used in the earlier simulations, has 80% power to detect the target response, 0.4, but the analysis, the simulation set above that that's based on high probability of getting at or near the target, it detects has power to detect a smaller difference. So what we learned from this exercise is that biomarkers that in this situation were useful for proof of concept, but not for clinical endpoint dose finding. From an efficacy dose selection point of view, the fastest development path for this situation should be to move to the phase 2B trial right after the early proof of concept trial based on the biomarker. And that's the short-term trial. The dose-finding profile from the POC plus dose-finding phase 1 information would not materially impact on the phase 3 dose choice. So the phase 1B dose-finding trial could be skipped, and that could result in substantial savings of resource and time, or the phase 1B trial, the phase 1B dose-finding trial could remain in the program and be conducted concurrently with the phase 2B trial and repurposed for other objectives like testing another dose regimen or getting dose response information on mechanism of action outcomes. In the context of overall drug development, if you consider a sequence of trial for an overall drug development program of biomarker proof of concept followed by biomarker dose finding, followed by phase 2 dose finding with the clinical endpoint, and then phase 3 based on the clinical endpoint, and resulting in probability of success or NPV, net present value of drugs, you could consider optimizing that drug program and then doing that for multiple drug programs and then optimizing the portfolio. The previous work that I talked about earlier focused on this phase 2, phase 3, and program POS and NPV space. And then there are references in the reference list with these slides that are being made available that deal with optimizing resource allocation across a portfolio of drugs based on POS and net present value of drugs. But we know of no work that links the phase 1 biomarker space to the phase 2 clinical outcome space, clinical endpoint space, and that's what this work adds to the development program. So now there are references and software available to optimize the early development space, optimize the late development space, and optimize across optimize resource allocation across portfolio. In conclusion, we learned that simulating a sequence of trials is useful in the early drug development space. That was shown by the previous work in the late development space, and now it is useful again. It is useful also in the early development space. In this particular example, biomarkers are useful for POC, but may be of only limited use for dose finding. Each development program is different. This applies only to one example, so it may be different with other biomarkers and other development programs. Still to consider to improve the use of biomarkers are to assess the impact of PK/PD relationship information, or employ, instead of a linear relationship model, some sort of more complicated mechanistic model that might do a better job of relating the biomarker response to the clinical endpoint. We didn't have information like that for this case, but if we get it, we might be able to apply it, and we might learn something different, and biomarkers may be found useful in those situations. Early development simulation could be added to late development program simulation to optimize across an entire drug development program. And already optimized development plans using approaches like these could be used across a portfolio and combined with portfolio optimization to assist senior management with resource allocation across their drug portfolio. The business benefit, the potential business benefit of all of this is, for the particular case we worked on, to eliminate a clinical trial from the critical path of an early development program, which could result in cost and time savings. And we've obtained software and experience which could be leveraged for other drug development projects. The reference list is shown on this last slide. It'll be available in the slide set that'll be made available on the web and to those who request it directly. I won't read through it at this time, but it's part of the slide set that goes with the presentation. So with that, I thank everyone for your attention, and we could move to some consideration of questions, comments, and any discussion.
And hi, this is Mike Weitz. I'm the Director of Marketing here at Cytel, and I'll serve as a moderator, if you will, for Jim. And we see a number of questions that have already come in from the audience. So we'll be selecting those, and please feel free to pose more questions and look into as many of them as we can. Before we get started with the question and answer period, I just want to remind everybody at the conclusion of the question and answer period, when the WebEx ends, you'll be directed automatically to a very short survey, but we really hope that everyone takes just a few minutes to complete the survey. It won't take more than a few minutes, but it really helps us to understand how we performed today and the information that you'd be looking for in the future that would be helpful from Cytel. Also, just to remind everyone, as you've probably seen through the question and answer responses, today's slides are available immediately in PDF form just simply go to cytel.com, and you'll follow the links on the bottom right that reference today's webinar. And then in 24 to 48 hours, certainly by Thursday, the WebEx replay of today's presentation will also be available for anyone to view at their convenience. All right, Jim, a number of good questions have come in. I'll start with a question that is often asked. Can you give us a little insight about how long it took to complete this particular work with Merck, and how long it took really to successfully implement the technique?
Actually, the work started last spring, and we had to present a report to the client by September. So from the start of definition of the project, program specification, completion of the programming, running the simulations, writing the report and summarizing the results, iterating several times with the client, and producing the final report, it was, roughly half a year. But now, having gone through that, the next phase, applying it again, could probably be much less.
Thanks, Jim. And here's a question from Louise Platt. And Louise asks that in the context of Alzheimer's disease research, and also in consideration of recent FDA guidance on early AD research, what are your thoughts on how cognitive endpoints such as CANTAB tests could be modeled? Do you have any insight into that? speculation?
I've worked with those endpoints in the phase 2 space, but not with biomarkers, and I'm not aware of biomarker relationships to those phase 2 endpoints. So if you are, you could consider applying this kind of stuff to that if you're aware of information that relates biomarkers to those cognitive endpoints. But I'm not aware of such relationships. And my experience in that field is limited to just phase 2 endpoints.
And Jim, I hope I pronounced this correctly, Yiji Zhao asked if you could explain a little bit about how the biomarker dose ranging info is used for the clinical endpoint dose ranging study.
Via that linear model. We have this prior linear model. We have this model, so we get the posterior predicted means for each dose from the phase 1B information, and we use the assumed true linear model to get a predicted response before we run the phase 2B trial, and we use that to pick the doses for phase 2B. But when we simulate the phase 2B data, then the biomarker information goes away, and we get the phase 2B results with the clinical endpoint. So that's what's used to pick the dose. The biomarker information is used to pick the doses for phase 2B via the relationship. And the coefficients have to come from prior data that relate the biomarker to the clinical endpoint. So this can only be used when you have prior information from either published literature or studies conducted in this disease with drugs of maybe other mechanisms and so forth. But you have to have the information to posit such relationships.
Thanks, Jim. Yu Wang asks if you can elaborate some on the insights and thoughts regarding how to build the model for relationship between biomarker and clinical response.
In this case, it was scatter plots. We had week 4 information and week 4 information on biomarkers and week 12 information on clinical response. From a scatter plot, we tried to fit models, but it would only, we only had enough precision to suggest a linear model. More information might yield better model fits, but linear looked reasonable enough. And so we used a linear relationship. But it started with a scatter plot and the usual type of modeling technique that you'd go through using paired prior data.
And Jim, Helmo Scheer first makes the observation that not all biomarkers are equal. If one has the option of multiple biomarkers, would weighing the different biomarkers separately move the program ahead to a clinical proof of efficacy or safety study?
The answer is probably yes, if they're positively correlated. We didn't do that. We had, for this particular case, had go, no-go criteria defined based on the separate biomarker information at the early design space. You probably could combine the two if you had clinical rationale to do that and improve the precision of the phase 1 trial in getting that proof of concept earlier. So I would expect yes. We didn't do that or consider it.
And Jim, that leads us to a question we often hear again. Are there therapeutic areas that this particular approach is well suited to? combining simulations with biomarkers, and for that matter, other areas that it may not be well suited to?
First of all, you have to have prior information that relates biomarker to the clinical response. I know there's a lot of work ongoing to develop biomarkers, and in some areas they exist. In oncology, tumor response is often linked with clinical outcome response. In pain, chronic pain, early pain response is often linked with late pain response. In obesity, early weight loss response, and there might be mechanistic responses that are tied to weight loss. So the key is, and statisticians working in their own therapeutic areas know whether the biomarkers are related to clinical response or not, but you need that. And so, those are just a couple of examples.
Could you see areas that
where it's not,
or
Alzheimer's probably. I mean, I don't know of good biomarkers with Alzheimer's, and since Alzheimer's has limited approved therapies, it's difficult to establish a relationship of a biomarker to a response without a highly effective therapy. So that's probably a very difficult area.
But we see a lot of work in oncology with biomarkers.
Yeah, I know that, but the biomarker response in oncology is more of the baseline biomarker to establish a subpopulation that will respond better. As far as early response to a drug to indicate late response, that might be less applicable, but tumor response is one that is often used, and that might be worth considering.
And Jim, thanks. But they also, Wenyang Hu, hope I'm pronouncing the name correctly. First of all, thanks you for a wonderful presentation. And asked, is the conclusion that the biomarker simulation is not useful to the dose finding specific to your drug development program, the Merck program? This methodology may not apply to other drug development programs?
Well, I think the methodology that we used is applicable in any case where there's a biomarker relationship to a clinical endpoint. The conclusion that the dose-finding biomarker trial was not applicable is only particular to this particular project that we did the work on. So it's only one particular therapeutic situation. It would need to be expanded to other potential relationships to answer that question. We had that question in our mind, and we did some simulations that increased the degree of correlation of the biomarker to the clinical response. And in this case, that even if we had a biomarker that was highly correlated to the clinical response, it didn't materially improve the probability of getting the phase 3 dose right. But we think that's because the variability in the phase 2 trial is so large in relation to the response we're looking at. And we only had a linear relationship. If we had a better mechanistic model relationship, then that might overcome that the variability in the phase 2 design. Furthermore, we didn't use a multivariate model that incorporated the phase 2B results. to analyze all the data together. It could be that that might improve things. But for the purpose of selecting a phase 3 dose, it would be hard to do that without having done it. It would be hard to do that the first time. And so when the sponsor embarks in a phase 3 program, they're probably only going to look at the clinical endpoint response. But that's, there's some room for improvement there that hasn't been addressed yet, because this is only the first step in those sorts of applications.
In fact, Jim, are you aware of instances where this technique or a similar approach has been utilized outside of this Merck project?
No. As I mentioned at the beginning, we're aware of simulating sequences of trials in the late phase space, but not in the early phase space. So if anybody on the line knows about that, we'd appreciate an email. I think my email address is on one of these slides. So, whoops. So you could let me know, because we'd really like to learn about that if it exists.
And Jim, Kai Grosch asks, where did the prior information come from, assuming the Emacs model and the assumptions on the parameter estimates? We had information from another drug in the class in which those Emacs models were applicable. So we assumed that they were applicable for the candidate drug development program for which this was being done. So that's another factor, that if you're in an area where, a therapeutic area where there is no drug already approved and information available, then, you would have to posit relationships, and you wouldn't have any substantial information to believe that they were applicable. In this case, we had that, because this program was not a first drug in a therapeutic area. Yiji Zhao asks a follow-up question to their earlier question. So if one is to skip the biomarker dose ranging study, how would the doses be determined in the clinical endpoint dose ranging study? In this case, they were chosen, there was a maximum dose that was feasible based on safety and formulation. And then when we went with the rapid to 2B option, we used that maximum dose, a half the maximum dose, and a quarter of the maximum dose. And those were the 3 doses in the phase 2B trial. And then we fit the Emacs model based on that. And Jim, Yu Lao asks, in the example that you presented today, your simulation concluded that the phase 1B dose finding study for a low-mid dose, that trial was really not a useful trial. Was that because the biomarker is not a predictor for the clinical primary endpoint?
No, it's more about that relationship that was existing was not sufficient to overcome the variability in the phase 2B response. Now, it could be that the other assumption that was made was that the ED50 was the same for the biomarker and the clinical endpoint. And also that in the rapid to 2B case, the maximum feasible dose and a half and a quarter was good enough to fit the model. And so, we didn't learn anything more for that case. If those doses were off from the target. In other words, if the target dose was much lower, and then that biomarker information might have been informative. So again, this is applicable to one specific therapeutic area and one specific configuration of dose response curves. It hasn't been studied outside of that narrow space. So, that's why the conclusion that it has to be applied for each case, because it just hasn't been studied over a wide set of cases.
Jim, Yu Lao asks, in speaking generally, does the FDA want to have low, mid, and high dose response curve to build the Emax model? That person's wondering, without the mid-low doses trial, what will be the suggestion method to build the dose response curve to support the dose selection for phase 3?
I think that depends on the therapeutic area. If there's a therapeutic area where drugs have come before the drug, then FDA is going to likely look for dose response information to justify that you have the lowest dose that yields a minimum clinically important response. However, if it's an area where there's no existing therapy or it's a life-threatening situation, then maybe the maximum tolerated dose without dose selection information might be acceptable. So I think that's on a case-by-case basis.
Thanks, Jim. We're just about at the top of the hour, and before Jim addresses the last question, I just want to, again, thank everyone on behalf of Cytel and Jim for joining us today, and again, ask you to take the survey when we conclude, and know that, again, the slides are available right now from Cytel.com homepage, and today's webinar replay should be ready by no later than Thursday. Again, follow the links from Cytel.com on the homepage. Jim, I'll let you address this question directly from Gary.
From Gary Meyer, does the software described here allow for estimation of, is that TI or TL, in addition to target efficacy to further refine dose selection? I got to know what TI or TL is, and that doesn't register.
Well, that's why I gave you the question directly.
I'm sorry.
Well, maybe you could speak a little bit about the software that was utilized.
Yeah, and Gary, feel free to email me afterwards to clarify. I'm happy to address that. The software available here exists within Cytel and could be applied to other programs. Yeah, we would be happy to do that.
All right, then. I want to thank everyone again for joining us today. Some excellent questions, and most of all, Jim. And we wish everyone a very good day, and we look forward to your joining us again. For those people who are interested in and certainly users of our e-software or would like to join a presentation next week, with our president and co-founder, Cyrus Mehta, and Cyrus will be demonstrating some of the new capabilities of EAST, including methodologies for adaptive trial design in pivotal trials, confirmatory trials. And you simply can register for this complimentary webinar by, again, going to the Cytel.com homepage. There will be 2 webinars that Cyrus will give next Tuesday, the 23rd, and Thursday, the 25th. Just choose the convenient time for you. They will be repeated webinars. Both, of course, will be live. And again, Cyrus, like Jim did today, will take your questions as time allows. So again, thank you very much for joining us here at Cytel, and we wish you a very good day.